Dr. Karen Tabb Dina is next. She is an associate professor, School of Social Work, University of Illinois at Urbana-Champaign, Illinois. She is also the faculty affiliate at the Carle Foundation Hospital and the Lehman Institute for Brazilian Studies and the Women and Gender and Global Perspectives. Thank you.
Hi, good afternoon, everyone. Thank you so much. It's an honor to spend the next 10 to 15 minutes with you all to talk about one of the most pressing topics as relates to maternal morbidity and mortality. Next slide, please. In all of the statistics that we have heard today, we need to make sure that we draw close attention to perinatal mental health for birthing people in this country. It's a leading complication of pregnancy and the postpartum period. So perinatal meaning pregnancy all the way through 12 months postpartum, and a major concern for individuals dealing with maternal morbidity in the postpartum period, if we start thinking about things with diagnosis related to stress, for example. This topic is so important because 1 in 5 birthing people, that's right, up to 20% of birthing people are going to experience a perinatal mental health problem during or after the time of giving birth. Perinatal depression takes the cake in terms of getting the most credit for perinatal mood disorders, and that is going to impact about 12 to 15% of all birthing people. Next would be suicidal ideation, which I've spent nearly 15 years of my life looking at suicidal ideation during pregnancy and the postpartum period, and can tell you that this is not as mild as it may seem. It impacts 2 to 5% of women, and it's one of the leading causes, being suicide completion, for maternal mortality. Perinatal anxiety shores up right next to depression, affecting nearly 15% of all birthing people. Bipolar disorder is something that we are learning more about now. In fact, there's a great webinar competing tomorrow, and there's a congressional briefing tomorrow where both suicide and bipolar will be brought to the forefront of these discussions of perinatal mental health, because bipolar disorder impacts anywhere from 0.5% to 2% of women, but can have some serious consequences, especially if there's a psychotic episode involved. And then perinatal psychosis gets most of the credit if you watch the evening news, but is extremely rare. Where only 1 to possibly 2 women in 1,000 women are going to experience perinatal psychosis, might hear thoughts, or hear the voice of a deity or God telling them to do something, maybe do something harmful to themselves or to others. And I live in a state that is now addressing people that have fallen through the cracks for things like perinatal psychosis and have ended up hurting someone or hurting themselves and are experiencing criminal corrections for that. So my state is working to address the unmet needs of individuals who experience the psychosis. Next slide, please. With all of the numbers that we've heard today as it relates to maternal mortality and morbidity, we know that women living in rural settings are more likely to experience maternal mortality or be at risk for maternal mortality. And Black and white rural women face increased odds compared to urban women, up to 30 to 50% more risk compared to urban women for maternal mortality. What we are now learning ever so recently using PRAMS data is that those risks are true and where it relates to perinatal depression as well. So women living in rural settings are going to be at greater risk for experiencing perinatal depression. A lot of this has to do with access issues. Maybe it's not being identified in time, detected with a need, or a lack of a facility to visit with the closing of healthcare facilities across the country. Next slide, please. In all of my work over the past decade, one of the most alarming things that I found are serious disparities as it relates to race, ethnicity, and perinatal mental health. You might be aware that there are differential rates of diagnoses than there are with symptomatology, where racial and ethnic minority women are more likely to express symptoms of depressive disorders, but are less likely to have a medical diagnosis in their chart. Regardless of this fact, my team has been working to document what those elevated symptoms are as a proxy for a depressive disorder. We've looked at racial and ethnic minority women in the Pacific Northwest and in the Midwest and found significant disparities among Black women, Black women of multiple identities, they say Black and Asian women. For Black women in this country, we find that the rates of depression are upwards of 10 to 30%, which is more than the numbers that we typically see. And suicidal ideation ranges between 3 and 17% for Black women. Next slide, please. In one of our recent studies, we looked at women who recently give birth in a Midwestern hospital. So 10,000 women who recently gave birth. This is in the maternity unit in between the same day up to 3 days after giving birth. And finally, depression is higher compared to white women when looking at Black women and Asian women. And alarmingly, suicidal ideation, so reports of harming oneself on the Edinburgh, item 10, are higher among Black and Asian women. And these findings held true through all of our adjusted analyses. Next slide, please. And another paper we conducted this year that just came out in 2021, it was featured in the National Institutes of Minority Health yesterday. We found that the trend in suicidality is increasing. So this is suicidal ideation and self-harm over an 11-year period. These are women who all have insurance, right? If you think Medicaid births account for half of the births in this country, this is a privately insured sample. And what we find among these individuals is that suicide is increasing over time. And then within this population, the greatest risk are for non-Hispanic Black women and for women with lower education. So again, this is speaking to the trend that we're seeing in maternal mortality with increasing suicide rates and the increase of suicidal behaviors in the perinatal period. Next slide, please. COVID has done nothing but to pour gasoline on our crisis that we're experiencing here already. We already had a slow burning fire of increasing rates of maternal mortality and a crisis of perinatal mental health problems in our country that are unaddressed. And then you couple that with a pandemic. What studies have found from across the globe, from Italy, Ireland, China, Canada, and the US, is that perinatal depression is now impacting upwards of 1 in 2 people. Psychological distress is impacting upwards of 1 in 2 people. Pandemic-related stress, that's the distress of having a pregnancy during the pandemic, and then thinking that you might pass the virus onto your unborn child, is impacting upwards of 1 in 3 women. And then anxiety is at levels that we haven't seen it ever before. So some studies are showing that 3 out of 4 is experiencing anxiety. And this is important if we think about untreated depression moving forward and risk for complications in the postpartum. I'll go ahead and say next slide, because it's just untreated risk are going to be untreated risk in the postpartum. This situation is costly, costing us $14 billion a year. Next slide. But it's not all doom and gloom. There are solutions. Next slide, please. We see that tech companies are stepping up to address perinatal depression. Earlier this year, Google came out. If individuals search PPD or postpartum depression, they're given a link to the Edinburgh Postnatal Depression screen, which they can take themselves, and then they have results similar to what are pictured. Next slide, please. We're finding that access programs across the country, so 17 states have access programs modeled after MCPAP for moms, show that collaborative care, as we've heard today, is an effective model for racial and ethnic minority women, rural women, and women who are pregnant, not yet postpartum. Next slide, please. There are brief interventions. So there is a task force panel that came out in 2019 that says we don't need 12 CBT sessions, cognitive behavioral therapy. We can use some brief problem-based therapy and as few as 2 sessions and get results. So there are proven methods that work within this population, despite all the barriers such as childcare, et cetera. Next slide, please. If we want a universal approach, screening is the way to go. So if we screen all women universally, we can tap into what those needs are universally. And across the country, several states have started to enforce mandates, such as my own state of Illinois. Next slide, please. There are several barriers that we know. Providers want to know what time, when to screen, how often to screen. Next slide. And we decided, after years of doing epidemiological studies of what the prevalence rates are, to learn if screening actually works. Next slide, please. We looked at the comparative effectiveness of depression screening in clinics by partnering with a public health district, a local hospital, collaborators from across the campus, next slide, and namely with patients. So we formed a patient advisory board, or you can think these are end users or service users who are pregnant postpartum individuals, their partners and their caretakers who have experienced a depressive episode or depression screen. They've gone on to work with us to design studies and to find out what works. We've learned from them so much about the screening process. In fact, we have one study under review right now saying that feedback is the most important loop. When people complete the depression screen, they would like a healthcare provider to tell them how they did so that they can make plans that better suit their needs. Lots of hesitancy around taking drugs or even finding the time for psychotherapy. But patients say, I would do things like yoga or pray more or meet with my advisor if I knew that that was an option. Next slide, please. Just an ending in this very brief introduction to perinatal mental health, I would say that the key points to carrying us forward are these universal approaches, such as universal perinatal depression screening using validated tools, acknowledging that mental health has exacerbated to levels that we've never seen it before during our current pandemic, and this is affecting birthing populations. Screening tools that are going to be appropriate, I would use things that are used across a life course, like the patient health questionnaire, and accompanying this with maybe the GAD-7, the general anxiety questionnaire, as appropriate based on those studies that show record numbers of anxiety. Clinical research innovation that uses the voice of stakeholders, as we've heard throughout the day, uses the voice of patients central, is needed and lagging, and we're falling behind. If we cannot address the needs of individuals living with the experience, we're not going to come up with long-term solutions that actually tap into disparities. For us, what we found in our projects is that community partners are key, and having patients as partners are key. Next slide, please. With here, I just want to acknowledge some of our providers. You see our advisory board members pictured. We have a website that the advisory board put together, and lots of information that we share, such as the mental health congressional briefing tomorrow, bipolar talk during pregnancy coming up tomorrow. So there are a number of resources, and I look forward to any questions that might come up. Thank you.